Assalamu alaikum.
Waalaikumsalam.
Waalaikumsalam, Doktor.
Good day for everyone. How are you? Good?
Alhamdulillah, good.
Okay, my internet inside the hospital may not be good. If it cut it, I will go through my phone. Let us start our meeting by Kitab.
Here are the listings for meeting.
We need only for the one who is presenting to make his microphone on. All of us, please mute our phone. The voice, okay. The second thing, we'll give him a chance to present. Then, if anyone has questionnaire, and we are going to put some comments if needed. Okay. The issue of problem-based teaching is a very important thing. We must try to practice because it will give us like thinking inventory. It is very important how we can think deeply. Diagnostic thinking inventory is one of the DTI, is one of a major issue which can help, especially the medical team, to come to the conclusion. Because a mini diagnosis looks like he is a febrile, we don't know what is behind that. He has a seizure, what behind that. So there is something common can done for everyone, but at the same time, the second half, there is something specific, which that's why our problem-based thinking and our problem-based seminar are very, very important. And I hope to make it as a habit in your medical career. Always, if you see any patient, ask yourself what is the main diagnosis and what is the differential diagnosis. What is the point positive and negative? So you will not forget the other diagnosis, okay? Now, it is a Floby infant, okay? Who is the presenter? Who will be the one to present? His name is not included. Okay, is it?
Three presenters today, Doctor.
Okay, go ahead, Fatin. Say Bismillah and start.
Okay.
How many candidates we are? Sorry?
Sorry, how many presenting, Doctor?
Okay, how many candidates?
Oh, total 26.
26, okay, so
Yes.
all, okay. Take care there that I may ask question for anyone, so keep alert with me.
Okay.
Start. You can start now, Fatin.
Okay. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and good morning to everyone. So today we will have a seminar including 3 topics. So I will cover the topic child with seizures and neonatal seizures. So you guys have to bear with me because my topic is quite lengthy, but I think it's quite easy to understand. Okay, next slide. So this is the table of contents. So I will be discussing with you all regarding the definition, pathophysiology, classification, the causes of seizure in children, clinical approach to children with seizure, and the last one, I will talk specifically about neonatal seizures. Okay, next. So we move on to the first subtopic. So we have to define first, what is seizure? Next slide. Okay, so what is seizure? According to Nelson textbook of pediatrics, seizure is defined as transient occurrence of signs and or symptoms resulting from abnormal, excessive, or synchronous neuronal activity in the brain. So it is important for us to actually differentiate between seizure and epilepsy, because seizure is actually a condition. Epilepsy is a diagnosis. So next. So here is the definition of epilepsy. It is actually a disorder of the brain characterized by an enduring predisposition to generate seizures by the neurobiological, cognitive, psychological, and social consequences. Just to make it easy, epilepsy is actually a diagnosis which have a clinical definition. According to pediatric protocol, there are two clinical definitions, but usually we use the first one, which is at least 2 unprovoked seizures occurring more than 24 hours apart. It is important to highlight the 2 unprovoked, which means that there is no underlying pathology or no underlying causes that can be found to be the cause of seizure. Or another clinical definition can be 1 unprovoked seizure and a probability of further seizures similar to the general recurrence, which is 60%, after 2 unprovoked seizures occurring over the next 10 years. But for me, it's easy to understand the first definition, which is 2 unprovoked seizures. Okay, next. So these are a few terms that we will come across when we discuss about seizure in children. So we have to know the difference between epileptic seizure, epileptic syndrome, and status epilepticus. So epileptic seizure is actually the same definition as seizure, like I mentioned before. So epileptic syndrome is an epileptic disorder characterized by a cluster of signs and symptoms, and it is classified on age of onset, seizure type, clinical features, EEG abnormalities, and MRI findings. So status epilepticus is actually a condition itself where any patient without improving level of consciousness within 20 to 30 minutes of cessation of generalized seizure activity. Okay, next slide. Okay, so this is the examples of epilepsy syndrome, which I get from pediatric protocol. You guys can go through it later. Okay, next slide. So moving on to the pathophysiology of seizure. So how actually seizure can occur in a patient? So in a normal healthy person like us, we have a balance between the excitatory and the inhibitory transmitters. So okay. And however, in patient with seizure, it has imbalance between excitatory and inhibitory transmitters, where there is excessive production of excitatory transmitters such as glutamate, and also low production of inhibitory transmitters such as GABA. So the excessive excitation will cause electrical impulse in the brain to be excessive, which causing seizure. Okay, next slide. So we move on to the classifications of seizure. This is actually a simple classification of seizure, which can be divided into 2, generalized or focal. So generalized has a few examples which I listed listed there, and also there is another classification which is focal seizure. Okay, next slide. However, according to the International League Against Epilepsy, they have made a framework to classify the epilepsy further, which they they classify the seizure according to the onset, which can be focal onset, generalized onset, or unknown onset. So next. So this is based on the manual ILI 2017. So focal onset, they define as a seizure originating within networks limited to one hemisphere. So we all know focal onset usually unilateral, only affect unilateral. generalized onset, originating at some point within and rapidly engaging bilaterally distributed networks. To make it easy, generalized will affect almost the whole brain, both hemispheres. And however, seizure of unknown onset still need further evidence to certainly define whether it is focal or generalized onset. Okay, next slide. So, however, they also come up with another expanded version of seizure types according to ILI 2017. So they actually replace a few terms that we use, such as the focal aware, used to be simple focal. Now we use as focal aware, and focal impact awareness used to be complex focal. And as you can see down there, focal to bilateral tonic-clonic used to know as secondary generalized seizure. Now we mention it as focal to bilateral tonic-clonic. Okay, so we have finished the first subtopic. Now we move on to the second subtopic, which is the causes of seizure. Okay, next. Okay, so I will only cover the causes for age more than 1 month, because neonate for age less than one month is considered as neonate, which I will cover later. So the most common causes of seizure in children can be many causes. However, the most common ones will be febrile seizures, genetic disorders, which can be epilepsy, and CNS infections, which is meningitis. So I will cover these three in detail. However, there are also, of course, there are other causes that can cause seizure in children, such as developmental disorders, head trauma, and idiopathic. Next. So move on to the first common diagnosis for seizure in children is febrile seizure. So febrile seizure is actually a seizure occurring in association with fever. So the child must have fever to diagnose febrile seizure. Okay, so it usually only affect children between the age 3 months and 6 years old. And how do we actually want to confirm that this is actually febrile seizure? There is no intracranial pathology found, and no metabolic derangement. So what are the risk factors for a patient to have recurrent febrile seizure? The first one is the family history of febrile seizure, and the age of the patient is less than 18 months, low degree fever, which is less than 38 degrees Celsius during the first episode, brief duration between onset of fever and seizure, which means that if the onset of fever and the onset of seizure is less than 1 hour, it is the patient will have higher risk to get recurrent febrile seizure in the future. Okay, next. The second one is meningitis, which is actually a red flag for a child with seizure, because it is still a major and sometimes fatal problem in pediatric patients. So it is important for us to rule out meningitis if patient presented with seizure, a child presented with seizure. So the likely causative organism can be different for all ages, for different ages. For less than 1 month could be group B strep or E. coli. 1 to 3 months, group B streptococcus, E. coli, Haemophilus influenza, or strep pneumoniae. For more than 3 months can be Haemophilus influenza, strep pneumoniae, or Neisseria meningitidis. Okay, next slide. And next one is epilepsy. So epilepsy is actually a diagnosis of exclusion. Just like I mentioned before, it is an unprovoked seizure, which means we cannot find any pathology so that we can diagnose epilepsy. The causes that I listed here is actually can cause epilepsy in patient. However, it is usually found to be negative in patient with epilepsy. So it can be due to physical, metabolic, or infection. Next slide. So these are other causes of seizures that you can read later. There are many causes of seizure in children. And of course, other than neurological causes, we need to also rule out other than neurological causes such as heart disease or any metabolic disorder. Okay. Are you guys okay? You guys still with me?
Yes.
Yes.
Okay, good. Okay, so we have come to the third subtopic, which is the clinical approach to child with seizures. Okay, next. So when a child was brought to the emergency department by their parents, usually their parents will complain that their child was found unconscious, or they notice any involuntary abnormal movement, or the child seems confused, or the child complained to them that they have confusion. Okay, next. So taking history from patient with seizure is actually quite different because we need to discover further the nature of seizure. So we have to divide into three, which is pre-ictal, ictal, and post-ictal. Pre is before the attack, ictal is during the attack, and post is after. So the first one is pre-ictal. We have to ask the parents, is there any warning signs? Warning signs here means that symptoms suggestive of red flag, which is suggestive of meningitis, such as high-grade fever, or the child have headache, or maybe vomiting, which can be due to space occupying lesion. And then we have to know what was the child doing before the attack. Was the child watching television in the dark, or was there any flickering lights nearby, which can be the triggering factors for the child to have the attack. And then any triggering factors, just like I mentioned before. And then we have to ask, was the child well? Here means that we need to exclude any metabolic, we need to exclude, for example, we need to ask the parents whether the child have diarrhea or persistent vomiting, which can cause metabolic imbalance, which will cause seizure. Or does the child have any fever, or does the child have any fever, which can exclude febrile seizure or maybe meningitis. And aura. Aura is actually quite hard for us to elicit for children, because in toddlers, for example, we cannot really expect for them to tell their parents that they have the weird sensation before the attack. However, we can try to rule out any aura in preschool children if they can tell. Okay, the next one is ictal, which is during the attack. It is important for us to ask the duration of the attack because we want to know the the type of seizure, and then how often was the seizure occurs in this patient, because we want to know if is it become more frequent. And then we have to ask any abnormal body movement. This is also to rule out to know the type of seizure, whether it involves tonic-clonic, which is generalized a seizure, or does it only affect one side of the body, which can be focal seizure. Any complexion changes, such as patient appeared sinus, which can indicate that patient have obstruction due to the tongue. And then we have to ask their parents, does the child injured themselves? Is there any tongue biting or any drooling of saliva or any incontinence during the attack? And then post-ictal, after the attack, we have to ask, how was the child? Does the child appear well? And how long does does the child appear drowsy, or is there any confusion after the attack? And then how long for the child to return to baseline, return to normal. And then it is also important to elicit floppiness or weakness after the attack, because you want to rule out any thoughts paralysis, which is usually common in focal seizure. Okay, next. And of course, we have to ask other associated symptoms such as fever or diarrhea, like I mentioned before, to rule out any other causes. And then other histories include the past medical, history of trauma, for example, head trauma, comorbidities, if patient have diabetes mellitus, type 1, usually in children, because it can, insulin injection can cause hypoglycemia, which can also initiate seizure in children. And also any history of CNS infection, such as meningitis. And for drug history, is there any history of drug withdrawal? Because drug withdrawal can also cause seizure in children. And if the child is already on anti-epileptic drugs, we have to know their compliance, and they have to know their compliance. Okay, and then the next one is nutritional history. Does the patient have poor feeding? Because poor feeding can lead to malnutrition, which can cause seizure also, because patient will have metabolic imbalance, which is hypoglycemia. And then next one is birth history, which is antenatal and perinatal complications. If patient have positive antenatal or perinatal complications such as prolonged labor or any prolonged labor, which can cause HIE, but this one will be discussed in neonatal seizure, which is very common cause of seizure in children. And then developmental history is cognitive. Is there any cognitive regression? Does the parents notice any cognitive regression? If there is positive cognitive regression, which means that the disease is actually quite severe. And then the family history, of course, we need to know about history of febrile seizure, history of epilepsy in family, and also developmental delay. And then for social history, we have to ask about drug abuse to rule out drug intoxication and physical abuse, which we need to rule out, because patient may have head trauma from non-accidental injury. Okay, next. Now we have asked about the history. So we need to move on to the physical examination. So from the physical examination, for general examination, we have to inspect the patient consciousness level. Is the patient conscious? Does the patient appear drowsy? And in dysmorphism, does the patient look ill, which can indicate that the patient might have meningitis or signs of head trauma. Okay, the next one, of course, the vital signs: heart rate, respiratory, blood pressure, temperature. If the temperature is high, can be due to febrile seizure or can be due to meningitis. And SpO2. And then for skin examination, we need, for pediatric patients, it's important for us to rule out any signs of this diagnosis, such as tuberous sclerosis, which includes hypomelanotic macules, or known as ash leaf. Bumps on skins include angiofibroma, cephalic fibrous plaque, Sjogren patches, and ungula fibroma. And for neurofibromatosis, we have to inspect for any cafe ole spot, and Sturge-Weber syndrome is port wine stain. And of course, don't forget the neurological examination, the tone, power, reflex, and the cranial nerve. And also don't forget about the Brudzinski and Koenig sign to rule out meningitis. Okay, next slide. So I have a few pictures. Okay, so can anyone tell me what is the first picture?
Fay-Aulé spot
No.
or neurofibromatosis?
No. Okay, that is hypomelanotic. So it is actually ash leaf in tuberous sclerosis. Okay, the second picture. Okay, I will tell you. The second picture is chagrin patches also in tuberous sclerosis. Next. Okay, so this one is angiofibroma, also seen in tuberous sclerosis patient. Okay, next one. Okay, this one is Café-Olé in neurofibromatosis. Okay, next one. Okay, the last one is port wine stain, which can be seen in patient with Sturge-Weber syndrome. Okay, so now we have done the physical examination, the history. So we need to do to proceed with investigations. So I divided the investigation into three. Okay, the first one is what to do with child presented with first seizure. So for pathology workup, we have to consider doing full blood count, BUS, serum calcium, magnesium, random blood sugar. If the child appear unwell, means that we need to rule out any metabolic imbalance or any fever, infection, or if the child is not alert. Okay, and then the next one is lumbar puncture. We need to consider for patient with seizure if we suspect any brain infection from the history and also from the physical examination. For drug toxicology, if there is any suspicion of drug abuse, for EEG, it is recommended to do for child presented with first seizure if the child is afebrile and there is no other pathology found that can cause the seizure. And then the next one is neuroimaging, which is MRI usually. It is done if the patient have persisting post-ictal focal deficit and if the condition of the child not returning to baseline after several hours, because we want to rule out any pathology. Next one. Okay, so for next one is investigation for child with febrile seizure. For pathology workup, we can do full blood count to rule out any infection. We want to look at the total white cell, urine analysis, or urine full examination or microscopic examination. This is also to rule out any infection. Blood culture and sensitivity, of course, to rule out infection. Lumbar puncture. So for lumbar puncture in patient with febrile seizure, it is not usually done. However, it should be considered if the patient's age is less than 12 months old and before we proceed with antibiotic therapy. And it must be done if there is signs of suggestive of intracranial infection and if the patient has persistent lethargy. For EEG, usually not indicated in febrile seizure. For imaging, we do plain radiograph just to rule out the causes of fever, because patient might have pneumonia, which cause the fever, which cause this febrile seizure. Okay, next one.
Just to remember, in case of suspected herpes simplex, sometimes the EEG can help in the diagnosis.
Oh.
It has left temporal lobe signs.
Okay.
Okay.
Okay. Thank you, doctor. Okay. The next one is investigation for child with epilepsy. So for blood investigation, we can do full blood count, renal profile. Full blood count, renal profile, serum calcium, random blood sugar, and liver function test. This one is just to rule out any metabolic causes and also for baseline purpose before we start on anti-epileptic drugs. Okay, so for neuroimaging, CT scan of the brain usually only done if a patient presented in emergency acute cases, for example, in the emergency department. And for MRI, we should consider to do if the epilepsy occurring in the first year of life, the child have focal epilepsy, has positive developmental regression, and refractory epilepsy. Of course, the most important investigation in epilepsy is EEG. So it is important to do EEG to support the clinical diagnosis, to classify the type of seizure of epilepsy, and also when we know the type, it will help us to select the right drugs for the patient and also to know the prognosis of the patient. However, normal EEG does not exclude epilepsy, because epilepsy can actually be diagnosed from clinical and also from excluding other diagnoses, other causes of seizure. Okay, next. So we already have done history taking, physical examination, and investigation. Now, how do we manage the patient? So for patient with febrile seizure, for child with febrile seizure, we need to advise the parents to avoid excessive clothing, and then we provide any antipyretic, for example, syrup paracetamol, 50 milligram per kilo, 6 hourly, and then advise parents on first aid measures during seizures. And then if the child has high risk for recurrence, it is important for us to advise the patients to learn how to administer rectal diazepam to the patient. Okay, next. So this is actually the first aid measures during a seizure. This one I get from pediatric protocol. You guys can read later. This one is actually just for practical purposes for the parents. Next one. Okay, for child with epilepsy, it is quite different for the management. So when the child is confirmed to have epilepsy, treatment is recommended if the child has more than two episodes of seizure. And monotherapy, remember to give monotherapy as far as possible. Do not give multi-drugs at the same time. Just prescribe one drug to the patient. So increase dose gradually until seizure is controlled or maximum dose reached or side effect occurs. However, if the first drug has failed, we can add on second drug. But we need to optimize the second drug first, and then we can try to withdraw the first drug. Okay. And then while prescribing the anti-epileptic drugs can help to control the seizure, but we have to also beware for any drug-induced seizure, because some drugs can actually exacerbate the seizure. Okay, and then in children not responding to treatment with two drugs, after two drugs, complete re-evaluation is required. Drug level monitoring is not routinely done except for patient on phenytoin or we suspect uncompliance. Okay, next one. Okay, so this is the anti-epileptic drugs according to seizure types from pediatric protocol. So they divide into focal and generalized. So the first line for focal can be carbamazepine, valproate. Second line, generalized. You guys can read it later. Okay, there are a lot of drugs. Okay, next one. So this one is for epilepsy syndrome. Okay, next. Okay, so this is what I meant from drug-induced seizure. Okay, so some drugs can cause can exacerbate, can cause the seizure to be worse. So for example, if the patient presented to you with to us with generalized tonic-clonic seizure, so it is best to prevent carbamazepine, because carbamazepine can actually worsen the patient's condition. Okay. Okay, next slide. Okay, this is the adverse effects of anti-epileptic.
Back to the previous table, please.
Sorry? Oh, okay.
This is it the anti-epileptic drug that aggravate? Okay, good, good. Thank you.
Oh. Okay. Next. So this is the adverse effects of anti-epileptic. So this one is also from pediatric protocol. They listed accordingly to the drug. Okay, next one. Okay, so this is the management of status epilepticus. So can you see the flow chart? It's actually quite small, I'm sorry. But this is also from pediatric protocol. So it is important for us to know, okay, when the child is presented with seizure and the seizure lasts for more than 5 minutes, we already classify the patient under impending status epilepticus. So what should we do, or the parents do at home or in the ambulance where there is medical assistance? So they should administer parental diazepam to the patient, and then, or if there is no diazepam available, they can give buccal midazolam to the patient. However, if the seizure persists, lasting 5 to 30 minutes, we already classify the patient as established status epilepticus. So when the patient reaches the hospital, we need to obtain the IV access and give IV diazepam to the patient. If the seizure still continue more than 5 minutes after the administration of diazepam, we give IV phenytoin. Okay, but however, if the seizure still persists, we consider the patient already have early refractory status epilepticus. So it is important for us to notify the neurologist pediatrician. Okay, you guys can read in detail later from the pediatric protocol. Okay, next slide. So when to refer, when we actually need to refer the patient to the neurologist pediatrician. Also, the first condition is when the patient have poor seizure control despite monotherapy with 2 different drugs, or difficult to control epilepsy beginning in the first 2 years of life, or we notice any structural lesion on the neuroimaging. However, it is important to immediately refer to the pediatrician neurologist if the child have behavioral or developmental regression or infantile spasms. So other than treating the patient, it is important for us to educate or give advice to the parents, because the parents are the one who took care of the child. So we need to educate and counsel the parents on epilepsy, so the parents will understand more about their child's condition and emphasize the compliance of the drugs. So it is important for us to emphasize their parents to ensure that the child is compliant to the medication. And then don't stop the medication without doctor's advice, because this can cause higher risk to get breakthrough seizure. And avoid sleep deprivation, because sleep deprivation can also cause seizure, can trigger seizure. And use a shower with bathroom door unlocked. This one is just to ensure the safety of the child, and not letting the child to do outdoor activities alone, such as cycling, swimming, because it is unsafe to leave the child alone doing outdoor activities. And then educate on emergency treatment of seizure, just like before, the first aid management. And then inform teachers about the child's condition so that the teachers understand about the child's condition, and then try to avoid so that the teacher can understand and avoid any triggering factors if possible. Okay, we have finished child with seizure. Now we move on to the last subtopic, which is the neonatal seizures. Okay, so as we all know, a neonate age group is from 0 to 28 days of life. Okay, so what is actually neonatal seizure? It is most common manifestation of neurological dysfunction in neonates. So in neonatal seizure, it is important for us to actually differentiate whether this baby is actually having seizure or not, because neonates may also exhibit paroxysmal non-epileptic events that can mimic seizures, okay, such as next. Okay, there are three. This one is according to pediatric protocols. The first one is jitteriness. Jitteriness is a stimulus sensitive, and it stops with gentle limb flexion. The next one is benign neonatal sleep myoclonus. This one only occurs when the child is sleeping, and it stops with when the child woke up. And the next one is startle disease or hyperreflexia. Excessive startle, stimulus sensitive jerks, and generalized muscle rigidity. So we have to differentiate between these and seizure. So I have provided the table so that you can further understand how to differentiate. Is this child having jitteriness or seizure? Okay, next. So this is the classification of neonatal seizures, divided into subtle, clonic, tonic, and myoclonic. Okay, next slide. Okay, so causes of neonatal seizures can be many causes. However, the most common one is the hypoxic ischemic encephalopathy, or in short, HIE. So usual age of onset is less than 3 days. As you can see, the table, the column preterm and term plus means it is most common in both preterm and term baby. So in patient with prolonged labor, have history of prolonged labor or abnormal presentation such as breech presentation during birth, the child will have higher risk to get HIE. Okay, next slide. Okay. So the investigations that can be done in patient with in child with neonatal seizure, the pathology workup include full blood count, BUS, serum calcium, magnesium, RBS, random blood sugar, FBC to rule out any infection, BUS, serum calcium, magnesium to rule out any electrolyte imbalance, also serum electrolytes. For random blood sugar, to rule out hypoglycemia or hyperglycemia in neonates, especially if the mother is has GDM or have existing diabetes mellitus. And then for blood gases, to look for ammonia, lactate, amino acids, septic screening, also blood culture, lumbar puncture for lumbar puncture to rule out any encephalitis. Okay, and then EEG. For EEG, for neonate patient, we do amplified EEG or continuous video EEG. So it stated that amplified EEG has become standard care in neonate after birth asphyxia for estimation of severity and prediction outcome. So amplified EEG is helpful to predict the severity and the outcome of the patient. And then for neuroimaging, we can do ultrasound, CT scan, and MRI. And these are other investigations that we can do if the causes of seizure still unknown. Okay, next one. So for management of neonatal seizure, usually neonatal, sorry. So for diagnosing neonatal seizure, it is actually adequate to gain history for prenatal and postnatal history, because from that, not postnatal, perinatal, during labor and postnatal history, because from that we can actually already rule out if there are any factors that can cause seizure in the child. Okay, so thorough history, physical examination, and neurophysiological assessment with AEG is required. So, like I mentioned before, important to identify the abnormal movements are seizures or not, whether it is actually seizure or not, because we don't want to overtreat the patient or mistreat the patient. For inacute settings, anti-epileptic drugs are given through intravenous. Usually, maintenance therapy is not required for neonatal seizures, because if the loading dose, the first dose, is already enough to control the seizure. However, prolonged maintenance therapy should be considered if one of these conditions occur. Patients have higher probability of seizure recurrence if there are any abnormal neonatal neurological examination upon discharge and abnormal EEG upon discharge. Okay, next. Okay, so this is the management of seizures, the guideline for management of seizures in neonates. This one is based on pediatric protocol. Okay, next slide. Okay, so the outcome or the prognosis of child with for neonates with seizure, so it actually depends on the underlying cause. So as you can see from the table, most of the patient will have 50 or more normal development, even though they presented with seizure in their early life. Okay, next. Okay, that is all from me. And these are my references. Thank you. Any questions?
I have a question, Fatin.
Yes.
Could you explain a bit more on the prolonged lethargy indication for lambang baca in prolonged lethargy?
Oh, the one in febrile seizure.
Yeah.
Or persistent lethargy, you mean? Oh,
persistent lethargy. I mean.
Okay. I'm not quite sure, but I think that if the patient have persistent lethargy, it may indicate that this patient have severe infection, which we need to rule out.
Okay.
Yeah, it is very important to not be distracted to one way. I mean, if the patient has a high-pitched cry or peevish cry or vomiting, you are going to suspect a meningitis. At the same time, if the baby has general infection signs, like a bit lethargic, like has petechiae, capillary fill time is increasing, there is mottling of the skin, all this can give you clue also for sepsis. Okay? So it is very important to take away, especially in neonates and small infant, you must be very cautious not to miss infection at that time. And even if severe lethargy looks like Todd's paralysis, after the conversion itself, it will be turned from simple to complex febrile. So must upgrade it for one. Any other questions? Hello? Good talk, Fatin, but you took 1 hour. I hope your colleague can tolerate 2 extra minutes.
It is a
Okay,
very
let us go for the second.
Good morning, everyone. Hello, can you hear my voice?
No, it looks you are preparing yourself to.
Can you hear my voice? If you cannot, please notify me.
Yes. Okay.
So Assalamu alaikum. I'm the next presenter. My name is Amira Azhar, and I will be presenting an important topic regarding acute flaccid paralysis. So this will be my content, which I will start off with introduction, followed by etiologies, diagnostic approach, and 3 diseases of acute flaccid paralysis. First, we need to know the introduction regarding the definition, case definition, and surveillance program. Acute flaccid paralysis, it occurs when there is a rapid evolution of motor weakness less than 4 days with a loss of tone in the paralyzed limb. This excludes weakness due to trauma and spastic paralysis. If we divide it into terminology, acute means rapid onset, less than 4 days. Flaccid is loss of tone, and paralysis is the limb weakness. So this is a very important topic because it is considered as a medical emergency, which is less frequently weakness of respiration and swallowing. However, it can progress to maximum severities within days to weeks. And if untreated or we treat it late, it can result in disability and also death. According to the World Health Organization, it defines acute flaccid paralysis as any child under the 15 years of age with acute onset of focal weakness or paralysis, or any person with paralytic illness at any age when polio is suspected, which is characterized by flaccid and without other obvious cause, such as trauma. So why the topic acute flaccid paralysis is very important? This is very important because it is concerning to the public health. In Malaysia, we have eradicated polio virus, which is one of the diagnoses for acute flaccid paralysis. So when a patient comes with you with any of these syndromes, as you can see in this picture, one of the diagnoses you must suspect must be poliomyelitis, which is due to poliovirus. So hence, there is a surveillance program which is launched by the Global Polio Eradication Initiative. This initiative is organized by larger organization, which is WHO and UNICEF. Their goal is one, which is to achieve a total polio eradication worldwide. As you can see in this, in the right side of you, there is a protocol for AFP surveillance in Malaysia, which includes several steps. You can read it later. All right, so AFP is considered as one of the infectious disease in Malaysia, and you must report it to the public health center. Let's move on to the etiologies of the acute flaccid paralysis. So basically, you can identify which the manifestation based on the anatomical site of AFP. As you can see, the picture I have shown to you, this is if the patient is having a lesion at the spinal cord, which is here, you can suspect the patient having acute transverse myelitis. If the patient is having a lesion at the anterior horn of the spinal cord, the patient might be having poliomyelitis, enterovirus. If it's at the dorsal horn, you can suspect patient having herpes, CMV, and rabies. And if it's at the peripheral root, GBS is common. Additionally, the lesion can be at the neuromuscular junction and also muscles. So these are the differential diagnoses that you can suspect. However, based on a research in 1997 until 2001,
we have one patient now, 10 years old, with transverse myelitis in the world, already diagnosed.
all right,
I don't know, probably you will see here. Okay.
Okay,
Continue.
thank you, Doctor. So based on this statistic, in the year 1997 until 2001, the main etiology that covers 30% is Guillain-Barré syndrome, followed by other etiologies such as CNS infection, transverse myelitis, non-polio, and many more. So for the disease, I will focus more on GBS, transverse myelitis, and poliomyelitis. But before that, this is the highlight of my presentation, which is how you want to diagnose the approach of AFP. So there will be history, physical examination, and also investigation. So this is an algorithm that I have got from the pediatric protocol. If a patient comes to you, age less than 15 years old, and there is weakness, so you must suspect and rule out several differential diagnoses. First, you must rule out CNS disorder, musculoskeletal disorder, and you must question yourself, this lower limb motor weakness, is it related to the sphincter? Either it is preserved or affected. For the sensory loss, is it preserved or is it reduced? And also the reflex. So based on this clinical question, you will guide yourself to give a clinical diagnosis. Either the lesion is at the muscles, peripheral nerve, and also spinal cord. So you will read the details later. Okay. So when we talk about history taking, you must take a very thorough history regarding to the patient. First, you take the history based on what the patient claimed, which is either weakness or paralysis. This is important because you want to narrow down your differential diagnosis. So for the paralysis, you will want to ask the development of paralysis in terms of duration, hours to days, and the distribution, symmetrical or asymmetrical. The progression, either it starts from your arms to legs, which we call descending, or from the lower limb up to the upper limb, which is ascending. Okay. Other features, you would want to ask for any inflammatory or infection. So we ask fever. So fever can present in polio, transverse myelitis, and many more. You ask also about any loss of sensation. So this can be seen in compressive myelopathy and GBS. Neck stiffness is also important in the diagnosis of polio, enteroviral myelitis, and also GBS. Bladder involvement, as I said before, it is regarding the sphincter. Either it is affected or not. So if it is affected, you can suspect patient with transverse myelitis, which is the spinal cord itself. For the cranial involvement, based on the specific cranial nerve, for example, if ptosis, it is regarding the third paralysis. So you might suspect patient having mesenteria gravis. If the patient facial weakness, which is cranial nerve 7, you suspect patient having GBS, MG, and also botulism. Don't forget, you must check also the spine, and you must ask the patient any back pain which is related to the spine. So we can suspect trauma, abscess. All right. Other from the neurological question, ask also other systemic history. For example, your respiratory. Patient can have shortness of breath in GBS and also poliomyelitis. And other history, you must rule out the risk factor. For example, trauma, environmental exposure, and also precipitating factors. Since we are talking about children, don't forget about the history of immunization, because this can affect the management, also the prognosis. After we take a complete history, we move on to the physical examination, in which, since this is a neurological symptoms, we must take neurological examination comprehensively, which includes TPR, tone, power, and reflex. Don't forget about the cranial nerve function and also sensation. So this table, I have mentioned about the features. For example, if you see there is a reduce of muscle tone, you can suspect patient having GBS, transverse myelitis, and poliomyelitis. If you do muscle reflex, you must see either the reflex is absent, preserved, or exaggerated. This will narrow down your differential diagnosis. Fasciculation is a sign of anterior horn damage, which is poliomyelitis. For the sensory impairment, you can suspect compressive myelopathy and transverse myelitis. Spinal tenderness, basically any trauma, any compression or abscess. And last but not least, assess for fatigability in myasthenia gravis. So we move on to the investigation. After you finish the history, PE, you do investigation to narrow down and to confirm your diagnosis. Basically, what I am presenting to you now is the basic investigation for AFP. So basically, you will do imaging, laboratory, and also specific studies. The most important thing is electrophysiological studies, which will determine your diagnosis and prognosis. This includes your nerve conduction, because you want to see the nerve, the electrical impulse in your neurons. The electromyography distinguish the denervation of myopathy involvement. For the laboratory, you can do creatine kinase. If it is elevated, you can suspect it is a muscle fiber injury, and also serum electrolytes. Hypokalemia can cause AFP. CSF analysis, if you suspect CNS infection, and imaging, the most important thing is MRI of the spine when you suspect any spinal cord lesion. Okay. So after I explain about the diagnostic approach or AFP, I will explain a little bit further of these three diseases, which is very important for you to know. So the first one, I will start with transverse myelitis. If you can remember from the anatomical side, transverse myelitis is the lesion that is within the spinal cord itself. So this is an acute demyelinating disorder of the spinal cord with cord swelling and loss of function. It is rapid and occur within the age group 3 years old and below, and also can occur in adolescent. So the cause is simple. It is 40% idiopathic and can be caused by infections such as virus, bacteria, and also parasite. Others, multiple sclerosis and SLE. So this is the clinical features. Since I mentioned, transverse myelitis is the lesion within that spinal cord. So that's the spinal cord. It can happen anywhere along the spinal cord. So the most common part is the thoracic region. And when it happens, this is a cross section. You can see a cross section of spinal cord. When I say it's in the spinal cord consists of many tracts that interrelates with your brain. So the manifestation of the patient, it manifests based on which tract it damages. For example, if it damaged at the corticospinal tract, which is at the blue region, it can cause weakness and problems with voluntary muscle movement. If it happens at the spinothalamic tract, it can cause loss of temperature and pain sensation. For the dorsal column, it can cause problems with balance and spatial orientation. So this is an overview of what I have said before. The important part is this table, which is the diagnostic criteria for transverse myelitis. So remember, it is bilateral and it is clearly defined sensory level progression can be 4 hours and 21 days after the symptoms onset. And the confirmation, you do investigation. So let's see. The investigation, you can see the picture here. This is a picture of the MRI of the spine. So what you want to see is the swelling of the spinal cord. So to see this, you put on a contrast, which is gadolinium enhancing cord, which can suggest inflammation if there is swelling. Other imaging such as MRI just to rule out brain lesion. And also you add on other supportive investigations such as CSF analysis and also antibodies. The management of transverse myelitis is basically you give a high dose of steroid, which is methylprednisolone. And if the patient does not respond to it, you give other approach, which is IVIG, intravenous immunoglobulin, plasma exchange, rituximab, and cyclophosphamide. We move on to the second important disease of AFP, which is poliomyelitis. Basically, polio is poliovirus, myelitis is the spinal cord, and itis is the inflammation. So poliomyelitis is a disease due to poliovirus infection.
Amira, for a while, can you come back for the MRI?
Okay.
This is a very important. So you can see the affection now for which vertebrae.
Cervical.
It is very important because if you need to MS, multiple sclerosis, usually this one will get a big amount or a big length of the spinal cord. Usually the other one, which is MS, will go maximum like 3 vertebrae, but this one will be a bit longer because we started to see some cases of pediatric MS. Okay, so you will find the affection is a bit lengthy in the spinal cord. Okay, it's very important to know that there is like patchy affection. You will find bilateral affection, but the motor power is different between both sides. So at the start, you may consider looks like hemiplegia, but then it is changing. You will find sensation, also affection. So it is very important to consider MRI early at that situation. Okay?
Okay. Okay. Thank you, doctor. So we continue with the poliomyelitis, which is the infection due to polio virus. So it is transmitted through fecal oral mode. Since Malaysia has eradicated this polio virus since 2000, but we do not forget, we're still on a watch out. That is why there is the surveillance program. So it is mandatory for you to notify the nearest district health office within 24 hours if a patient is suspected to have this poliomyelitis because it is infectious. So here I would like to emphasize on the pathogenesis of poliomyelitis for you to understand the clinical manifestation later. So basically, when a poliovirus enters the body, it will attack your digestive system, for example, oropharynx and small intestine. So when it enters your cells, this is the virus, this big virus, it will release the viral RNA. This viral RNA will attack your ribosomes. It will attack your ribosomes, making it making commands to synthesis more virus protein. So when the poliovirus is replicating inside the cell, as you can see from one to many, they will eventually go out of the cell and attack other structure. The important one is the lymph nodes, because the lymph nodes, it control our immunity symptoms. So when it attacks the lymph nodes, it will go inside our bloodstream. So when it goes inside, leaves the blood vessels, it will enters the interstitial tissue. so invades our motor neuron. As you can see, the arrow is pointing backwards, which is retrograde. The movement of poliovirus is retrograde until it reached the anterior horn inside the spinal cord. So the neurons that is affected, it will attract the immune cells such as neutrophils, macrophage, causing inflammation and damage. Eventually, the neurons will die. This will affect the trunks and limbs. So there will be no transmission of signals, causing muscle atrophy. So that is an overview of the pathogenesis in poliomyelitis. So this is what I'll be saying, the clinical features. It affects your muscle, but initially it starts off with a simple fever, headache, vomiting, constipation, neck stiffness, and limb pain. And then eventually, patient will have muscle weakness within 1 to 2 days. Commonly, it affects your proximal muscle and more to the legs. You will have, it will affect your tones, your reflexes, and also bulbar involvement, which controls your swallowing, your speed. So this is a girl with poliomyelitis. As you can see, she has abnormality of the lower limb. Important to note, you investigate poliomyelitis is based on stool. Virus, you must isolate the virus from stool. At least 2 specimens you must take with an interval of 24 hours. Okay, other investigation to support your diagnosis is CSF analysis, which will show virus signs with high protein levels, plocytosis, and patient can have normal glucose level. The management of poliomyelitis basically is supportive with a pain relief. You do physical therapy and also give mechanical ventilation if the patient have respiratory failure. That is why every children, you must follow the vaccination schedule. We give the, in Malaysia now, we give inactivated poliovirus. Okay. So the last part of this presentation is GBS. So GBS occurs in the peripheral spinal cord, as I mentioned before in the anatomy. It is an autoimmune disorder due to post-infectious polyneuropathy. It can affect anybody. It can affect people of all ages. And most importantly, it is symmetrical and ascending from your lower limb to your upper limb. So this is the pathogenesis for you to clear. It is due to infection, for example, virus or bacteria, in which it will trigger your immune response and produce antibody against the microorganism liposaccharides. So they will share homologous antigen between the liposaccharide and our nerve ganglioside. So when these antibodies cross-react with specific ganglioside along the myelin, this will affect your myelin sheath, causing demyelination. So nerve impulses cannot be transmitted successfully in your neurons, causing a delay and impairs. Okay. This is the clinical features. For easy understanding, you can see the picture. First, it is symmetrical, and then it is ascending from your lower limb to your upper limb. And patient can have advanced symptoms, such as patient can have, apart from the paralysis, and also patient have reduced or absent muscle reflex, peripheral symmetrical paresthesia in the hands and feet. They can also have neuropathic pain. This is 2 out of 3 of patients. It can also affect your cardiovascular autonomic dysfunction, which is arrhythmia, your bladder function, and also intestinal dysfunction. So don't just look at the CNS, look at other systemic examination also. For the investigation, this GBS is a clinical diagnosis made by history, which is progressive, ascending, symmetrical. And when you do investigation, you want to see elevated CSF protein level and a normal cell count. So nerve conduction study is the confirmatory is a confirmatory investigation. This nerve conduction study, you want to see the impulse transmission. This I stated furthermore is your other supportive investigation that you want to rule out. Okay. For the management, I divided into three, which is initial measures, specific measures, and general. So for the initial, you give oxygen if the patient is having respiratory distress. You monitor the PEFR regularly and you admit the patient to PICU. So this is if the patient is having a respiratory compromise, any rapid progressive tetraparesis, which is the weakness of your four limbs, bulbar pulses, and also autonomic and cardiovascular instability. For the specific measurement, you give IVIG because this is an autoimmune disorder. So you give IVIG 2 grams per kilogram total over 2 to 5 days. For the general measures, you give prophylaxis to avoid deep vein thrombosis. Should be considered in patient for patient ventilated for GBS, especially if recovery is low. And if the patient is having pain, you give NSAID, paracetamol. So this is a summary of the three diseases that I have mentioned. We have transmyelitis, polio, GBS. You can see all the points I have mentioned before in the slide, but this is a summary of, you can see each, how it progresses. Okay. So in conclusion, acute flaccid paralysis. First, you need to know it is rapid evolution of motor weakness less than 4 days with a loss of tone in paralyzed limbs. It is a medical emergency. Don't take it for granted. And you must notify the public health within 24 hours. Do not delay. If you delay this or you cannot figure out the diagnosis of AFP, this can lead to patient having disability and also death. So this is my reference. Any questions? Hello.
Yeah, we have a good presenter now, mashallah, in this group.
And Doctor, I would like to confirm about the ascending paralysis. Is it start from lower limb to upper limb, or it start like it can be both upper limb and lower limb in at the distal part and then more proximal? Which one is ascending paralysis or ascending weakness?
Amir.
From my reading, the ascending paralysis, mostly it occurs at the lower limb distal and going up until your arm.
So it is very important for this, if you suspect the way of ascending, it will start from the lower limb. It is going up, up, up until it came to the intercostal chest muscle. At the time, the patient will get respiratory failure, secondary to muscle paralysis. If you didn't put the patient on mechanical ventilator at the time, he may die. That's why it is very important for close observation and regular lung function, even by just spirometry. In some area, we are asking just the patient to count from 1 to 20, how much he can. He will say 1, 2, 3, 4, 5 by only one breath until he came to like 20. If he started, he cannot complete that one. So it is a very important clue. But usually we are using spirometry if he started to feel, because he will not be distressed. He will be as if you are giving the patient like muscle paralysis. So he can die in a piece, which is a very, very, very big error. So if you suspect that, try to diagnose early and manage early, and they know that if you are able to support the ventilatory for a few days by mechanical ventilator until the patient retrieve, he will escape that one.
So about the ascending paralysis just now, the trunk affected first or the upper limb?
It will start by upper limb and going up slightly for the spinal cord. When it came to the chest, because the chest, all our upper limb is a part of it. Until T1, all are affected by, if it come to the upper limb, usually the cysts are affected at the time.
Okay, thank you, Doctor.
Doctor, how common is there's facial involvement in GBS?
How common is?
Facial involvement in GBS.
It happens. I think there is even subspecialty of it, which can affect the facial, and recorded some cases can even be bilateral affection, which can be undiagnosed because it's bilateral weakness at the same time. But it happens, yes.
All right. Another thing I would like to confirm, for GBS treatment, we have IVIG and also electrophoresis, right? In clinical setting, do we do both or we choose either one? Thank you.
You need to answer, Amira, or should be me?
I'm not sure about which one we start first.
IVIG is the most simpler one, but we keep the other one. It looks like renal dialysis, but you just make it for dialysis of the antibody inside the blood. So if it is severe and non-responsive, you will consider. And you must remember that the CSF findings are very important, which is, Amira, what is the CSF findings?
CSF findings in GBS.
Yes. I didn't prefer to tell GBS because it can be group streptococcal. Another thing.
So, GBS, if it is based on the etiology, if it is caused by bacteria, you will see the CFS analysis appearance is turbid. If viral, it is clear. Next, in CSF analysis, you check on the protein. If bacteria more than 1, for viral is less than 1. So the CSF analysis is based on the etiology of the patient which is having that cause.
Specifically, I think what Farah Imanina mentioned, cytoalbuminergic dissociation, protein cellular dissociation.
Yes, this is the top importance, known as protein cellular dissociation. We'll find the protein is high, but there is no more cell, no cells. So it means it is not so infectious. It looks like autoimmune. So protein cell dissociation is one of the criteria of diagnosing. Even if you cannot find signs of infection, you must do it because it will guide you. Okay, so the lumbar puncture is very important. You need to add it. Okay. Any other questions?
Doctor, before we proceed to another topic, this is pertaining to the epilepsy. Can you explain why we define epilepsy as unprovoked seizure when in reality there is always causes behind that seizure or that epilepsy?
No, it depends on the type of the epilepsy itself. Some epilepsy can be provoked by external stimulation, okay, like photo light. Many patients, if he got like fatigued, he exposed to, even if the TV do lightning like that, he can get it. So some cases are not affected and some can be, okay. But it is very important to know the baseline of the patient. And even during EEG, if the patient doesn't show any convulsion, sometimes you are doing like a sleep deprivation, like photostimulation. All this will guide us to detect the epilepsy because depends at which neurons are affected and the type. Is it congenital or is it acquired? What is the pathology? It is just simple or behind like some developmental delay, especially in pediatrics. So it is an important step. It is not a must for all patients, but it occurs with some types of epilepsy and for some patients also.
All right, understood. Thank you, Doctor.
Okay, now we have one more, Shaimi. Okay, where is the boys today? No boy will coming to present today. Okay, go ahead. Yes, Shaimi.
Okay, Bismillahirrahmanirrahim. My name is Wanur Syamimi binti Wan Ismail. So I will be the last presenter for today. So my topic is floppy infant. So next slide. So here is my outline. So I will be starting from the definition up to the management. Next slide. So in order to understand about the definition of the floppy, so we need to understand a few terminologies first, which are hypotonia and also weakness. So hypotonia, according to the Nelson textbooks, it is defined as diminished resistance of muscles to passive stretching, and weakness is defined as decreased ability to voluntarily and actively move muscles. So next slide. So, in short, floppy infant is defined as infant who has generalized low tone or hypotonia, which can be associated with weakness or without weakness. So, next slide. So, in order to investigate or to know further about hypotonia, so we need to understand about neuroanatomical position, which can lead to better diagnosis later on. So if the hypotonia is associated or manifested with upper motor neuron signs, it is usually due to central causes, and it can cause the infant to have floppy strong, meaning that the infant is hypotonia without weakness. And if the hypotonia is associated with lower motor neuron signs, it is usually due to peripheral causes, and it can cause the infant to have floppy weak, which usually means that the infant is hypotonia with weakness. Next slide. So here are the causes for the floppy infant. So they can be divided into central and peripheral, as I mentioned earlier. So for the central, the pathology can be at the brain or spinal cord. For the peripheral, the pathology can be at the anterior horn cell, peripheral nerve, neuromuscular junction, and also muscle. So here is the illustration. As you can see, if the pathology occur at the brain and spinal cord, so it can affect central nervous system. So there are a few diagnoses that relate to the central nervous system. For the peripheral, it can affect motor neuron, which is anterior horn cell. It can also affect peripheral nerve, NMJ, and also muscle. So the one that I highlight in the red box, which I will explain further in the next few slides. Next. So for the central causes, as I mentioned earlier, it can be pathology in the brain and also spinal cord. So as you can see, in the brain, there are a lot of causes, such as brain tumor, trauma to the brain, any infection, ischemia, hemorrhage, metabolic diseases, degenerative diseases, and also genetic abnormalities, such as Down syndrome and also Prader-Willi syndrome. For the spinal cord, as you can see, it can be due to transverse myelitis, any tumor, any abscess or any trauma to the spinal cord or infarction. Next slide. So this is one of the common causes at the brain, which is the genetic disorder, Prader-Willi syndrome. So it is a chromosomal disorder where there is loss or deletion of the paternal copy at the 15q11 to q13. So usually, infant who has Prader-Willi syndrome, they manifest with severe hypotonia, where they call as neonatal hypotonia, which is the hallmark of this Prader-Willi syndrome. In the early life, they have feeding difficulties. And in the early childhood, they also can have unregulated appetite, meaning that they have what we call as chronic overeating, hyperphagia. So when they have this chronic overeating, they are easy to gain weight. So that's why it can lead to childhood obesity. And this childhood obesity later on can complicate into type 2 diabetes mellitus or maybe obstructive sleep apnea, OSA. So this infant who has Prader-Willi syndrome also have growth hormone deficiency, lead to short stature, sleep disturbances. They also have secondary hypogonadism, intellectual impairment, and also learning disability. They also can have strabismus, small hands and feet, and also behavioral problems. Regarding behavioral problems, they can have what we call as tantrum and also conductive behavior, which can have problems if they go to school, go to the kindergarten later on. Next slide. So that's for the central causes. Now we go to the peripheral causes, which can be divided into four: anterior horn cell, peripheral nerve, NMG, and also muscles. So for the anterior horn cell, the common diagnosis is the spinal muscular atrophy, poliomyelitis, as discussed earlier on. For the peripheral nerve, GBS, as mentioned earlier on the previous presenter, hereditary motor sensory neuropathy, HMSN, or known as Charcot-Marie-Tooth, tip paralysis, and also Bell palsy. Next slide. For the neuromuscular junction, the common causes is due to myasthenia gravis and also infant botulism. For the muscle, it can be any muscle disorder such as muscular dystrophy, myotonic dystrophy, any congenital myopathies, metabolic myopathies, dermatomyositis, and also polymyositis. Next slide. So for the peripheral causes, I will be focusing on spinal muscular atrophy. So this spinal muscular atrophy, or known as SMA, is autosomal recessive, where there is degeneration of the anterior horn cells at the spinal cord. So it can lead to the progressive weakness and also wasting of the skeletal muscles. This occur due to the mutation in the gene called as survival motor neuron gene, SMN gene. So the clinical features of the SMA patient is that they have severe hypotonia, generalized weakness, usually proximal weakness. They also have tongue fasciculation, and they have absent deep tendon reflex, areflexia. So as you can see in the picture of the child, in the picture on the right side, so this is you can see the child, the type of the child is in abducted position due to the hypotonia, and you can see there is a chest, what we call as chest deformity, because of the weakness of the intercostal muscle. Next slide. So there are three types of SMA. So it is according to the age of the onset. So for the SMA type 1, it occurs at birth up to 3 months of age, and usually it is the most severe form of the SMA. For the SMA type 2 and type 3, it occurs later in life. For SMA type 2, it occurs at 3 months to 15 months of age, and it is a more slowly progressive form. For the SMA type 3, it is chronic, so it occurs after 1 year of age. Next slide. Another peripheral causes, which is at the neuromuscular junction disorder, the common diagnosis is the myasthenia gravis. So it is an autoimmune disease. So there is autoantibodies that block the acetylcholine receptor at the neuromuscular junction. So there will be decrease of the receptor. So it will then cause rapid fatigability of the striated muscles. So there are three types of myasthenia gravis, which are juvenile myasthenia gravis, transient neonatal myasthenia, and also congenital myasthenia. The clinical features of myasthenia gravis are ptosis, as you can see in the picture on the right side. They also can have diplopia. They also can have poor feeding, poor head control, hypotonia, extremity weakness, usually at the proximal, and also respiratory difficulties. So for the myasthenia gravis, there are also, as I mentioned, there are 3 types. So for the juvenile, it occurs at the late infancy up to the childhood. So this myasthenia gravis of juvenile myasthenia gravis is limited to the ophthalmoplegia and ptosis in some patients. Others can have progressive and potentially life-threatening. In transient neonatal myasthenia gravis, it occurs in the neonates period, which is at first hours to days after birth in neonates in a mother who have myasthenia gravis. And for the congenital, it is not autoimmune mediated, and there is a gene mutation in the components of the neuromuscular junction, and these patients who have congenital myasthenia gravis usually have lifelong disability. Next, we go to the highlight of the slide, the presentation today, which is the approach to the floppy infant. So usually when the mother or the parent comes to the clinic, so they will complain a few chief complaints. So what they complain is that the first is that their child or their infant is floppy since birth. Another complaint is that they have a frequent fall due to the weakness. They also can have a complaint of when they try to lift their child tends to sleep during lifting. And another complaint is that they can have poor suckling during breastfeeding and also weak crying. Another important point to take note is that if at term the child is normal, meaning that there is no hypotonia, there is no weakness. However, later in 1 or 2 days of life, if they come with hypotonia, you need to suspect what we call as inborn error metabolism, IEM. So you need to suspect IEM. Okay, so for the approach, we go to the history first. So you need to know the onset to know whether it is congenital or acquired. If it is occur at birth, usually it is congenital. If it is occur later at life, it can be due to acquired causes. Another important, what you need to ask the parent is the cause of the disease, cause of the floppiness, cause of the hypotonia. Is it static, which can suggest cerebral palsy, or is it progressive, like in the spinal muscular atrophy, SMA? Next, you need to ask also any associated symptoms such as weak crying, poor feeding, or any weakness of the, on any disability of the swallowing which can cause drooling, any seizure which can point out to the central causes, any lack response to visual, auditory, and also drowsiness which also can pinpoint to central causes. Next slide. Next, you need also to ask regarding the birth history. First, you need to ask the mother if there are any reduced fetal movements in the antenatal, meaning that the fetal movement is reduced, meaning that there is neuromuscular disorder earlier on. And is there any breech presentation? Because we know that breech presentation has higher risk for the infant to have neuromuscular disorder. We know that turning in the womb is very important for the child to have adequate mobility. So that's why we need to ask about breech presentation. We also need to ask about poly or any oligohydramnios. We need also to ask any birth trauma, delivery complication, low cord pH, and Apgar score, because all of these points can cause hypoxic ischemic encephalopathy, HIE, which the patient can manifest with hypotonia. Next, we need to ask about any congenital infections from the mother, like torches. We know that toxoplasmosis, any rubella infection, any cytomegalovirus infection, herpes simplex. So we need to ask them. Next, is there any history of honey consumption? Because we know any raw honey consumption to the neonates, to the infant, can predispose to the patient to get infantile botulism. Next, we need to ask family history. Is there any consanguinity marriage? Because consanguinity marriage has higher risk to get a genetic disorder. And is there any other affected family members? So for the physical examination, first you need to look at the general examination of the infant. You look if the patient is alert or not, because drowsiness can lead to the central causes of the hypotonia. Next, we look at the quality of crying. Is it high pitch? Because high pitch can can suggestive of central nervous system causes like infection in meningitis and so on. And then look at the posture of the infant, such as in hypotonia patient, they usually have what we call as frog-like posture, F-R-O-G, frog-like posture. And look also dysmorphism, because we know patients who have hypotonia usually have genetic disorder. So they can have Down syndrome, they can have Prader-Willi syndrome. So they have dysmorphic features according to each disease. Next, for the neurological examination, we look at their head and neck, we look at the cranial nerve, because we can see that some of the patients, they have diplopia, they can have ptosis, they can have strabismus, so we need to check for the cranial nerve. Next, check for the limb examination for tone, for power, and also for reflex, because we need to determine either this patient have upper motor neuron sign or lower motor neuron sign. And next, for the hypotonia evaluation, which we need to assess the posture of the infant, the vertical suspension, horizontal suspension, and also traction response, which I will explain further on the next slide. Next slide. Okay. So here is the picture. As you can see on the left picture, it is the child with Prader-Willi syndrome. So the posture is due to the hypotonia. In the middle picture, as you can see, there is ptosis and also external ophthalmoplegia, which can suggestive to myasthenia gravis. For the right side, the most right picture, it shows tongue fasciculation, which is the suggestive of the what we call as SMA. Next. So for the neurological examination, as I mentioned, it is very important because we want to differentiate either this patient has upper motor neuron lesion or lower motor neuron lesion. I think all of you are familiar with this. So we need to assess with tone, reflex, any Babinski, any atrophy, and also any fasciculation to differentiate either this patient has upper motor neuron sign or lower motor neuron sign. Next.
What is the clonus?
Yes.
Where is the clonus? We must
clonus.
add the clonus.
Oh yes. Yes, clonus should be positive at the upper motor neuron sign and negative on the lower motor neuron sign. I will add later on.
Presenter of you while commenting even forensic examination, Fatin said TBR, which is tone and power and reflex. You must remember the ABC after that. What is the ABC? A is the ataxia, which is very important. Don't forget the ataxia sign, and B is the Babinski, and the C is the clonus. During the exam, most of the candidates are forgotten this one until asked to do. So after TBR, you must go for A, B, C. A is ataxia or incoordination, and B is the clonus, and C is the, B is the Babinski, and C is the clonus. Okay, it must be added here also.
Okay, thank you, Doctor. I will add on the slide later on. So next we go to the hypotonia evaluation. So as I mentioned earlier, there are 4 evaluation. First, you need to look at the posture of the baby, of the infant. Usually they will have a frog-like posture. And also next is the vertical suspension, where you try to leave the infant where you hold at their axilla. So normally in the normal infant, they will flex their knees and also feet. However, in hypotonia patient or in floppy infant, they will have hanging leg and also scissoring. So they also tend to have slip through shoulder due to weakness over the muscles in the shoulder. Next is the horizontal suspension, So normally, they will maintain straight back with upright head and also limb flex. However, in hypotonia, because of the muscle weakness and low tone, they will have inverted U shape. And the last one is the traction response, where you try to pull the child, the infant, so they will have extreme head lag. So it will be clear with the pictures on the next slide. Next slide. Okay, so this is what I mentioned. On the left side is the posture, meaning that the child will have frog-like posture, as you can see. And on the middle picture is the vertical suspension, where you try to lift the child and by holding their axilla. So you can see that the leg is hanging, not flex in the normal patient. And they can slip through your hands in vertical suspension. So on the right side is what we call as a horizontal suspension, where you try to hold. So you can see there is no head upright, the back is not straight, so it will look as inverted U shape. Next slide. So for
this one to the left, can you come back, please? This one looks like normal. No, come back to the previous slide. This one looks like normal. Usually leg will be both leg and hands are very, very hypotonic, so they are extended like that. I think you need to choose another picture of hypotonia. This baby, his hand looks like not so hypotonic. The other one, yes, you must take care about the baby maybe slipped from your hand. If you put your hand below the axilla, you will try to slipping from your hand, because his muscle at the axilla are very weak. So it is an important sign. And to try to remember, the best thing to do is an important test. Try to concentrate on it. It is known as 180-degree test. 180-degree. I mean, you will, while the baby is like that, you will see is frog leg or not, and then you will catch both hand and try to check if there any head lag or not. Okay. Then you will come and carry him from the axilla and see he is sleeping or not. And then put him in one hand and see how much is the arching of the head. Is it straight or arched? And then what about the head also is lagging or not? And then put him on the bed again and see he can move his head from side to side. He can raise it and then drop again. Or when you put it him, he will be the same. This is known as starting from the left until he came 180-degree and he is staying. All this will give you a clue, is it hypotonic or not? Okay?
okay, doctor. So next slide. So this is what head lag looks like on the left picture.
Yes.
Okay, so you can see that there is head lag. So you need to do with care, because due to this head lag, it is very dangerous because their head can bump onto the floor. So you need to be careful by doing that. So next slide. So as I mentioned earlier, so in hypotonia infant, so they will manifest.
You must catch the baby. You must catch the baby by one hand. Shami, you must catch both hands by one hand and put the other hand below the head. If it is going to be more dropping,
okay, doctor. Thank you. So I will continue. So in hypotonia or floppy infant, so they can manifest as upper motor neuron sign and lower motor neuron sign. So as I mentioned earlier, they in upper motor neuron sign, there is known as floppy strong, and lower motor neuron sign, they usually known as floppy weak, meaning that they hypotonic with a weakness. So next slide. So in floppy strong, meaning that the child is floppy, is hypotonia. Together, with no weakness. So they can have hyperreflexia, they have extensor plantar response, they have clonus, they can have global developmental delay, they can have microcephaly or suboptimal head growth, they have obtundation convulsion, and axial weakness. For the floppy weak with lower motor neuron sign, so they can have hypo up to areflexia, they have selective motor delay, they will have normal growth with preserved social interaction, and they have weakness over anti-gravitational limb muscles, they have low pitch weak cry usually, and they have tongue fasciculation and paradoxical chest wall movement. Next slide. So we after we done with the history and physical examination, we go to the investigation. So if the child have hypotonia, so according to the physical examination, you can already narrow down either it is central or peripheral causes. So if you suspect this child have central causes, so you need to do karyotyping or neuroimaging. So you need to look first at dysmorphism. Is there any dysmorphic features? If there is any dysmorphic features, such as in Down syndrome or Prader-Willi syndrome, so you need to do karyotyping, or you can combine with a fish to know either this patient has any genetic disorder. If there is no dysmorphic features, so you straight away go to the neuroimaging. So you can do brain MRI to look any other causes such as genetic and metabolic. So for the peripheral causes, as we can see, there are a lot of causes such as anterior horn cell, peripheral nerve, NMG, and also muscles. So first, you try to rule out any genetic disability, any genetic disorder. So you need to do specific genetic for example, in SMA, as I mentioned earlier, there is a SMN mutation. If there is no genetic abnormality, so you go to do muscle biopsy and also EMG and nerve conduction studies. Next slide. So here is the same, but elaboration more on the central causes. So usually, the patient who has hypotonia due to central causes, they will have normal creatine kinase and with global developmental delay. So as I mentioned, they can have dysmorphic features, and these dysmorphic features, you can do separate investigation for any suspected diagnosis, any suspected disease. For example, in Down syndrome, you can do chromosomal study. In congenital disorder of glycosylation, CDG, you can do isoelectric focusing. For any paroxysmal disorder, you can do very long chain fatty acid and others as shown. Next slide. So that's for the central causes. Now for the peripheral causes, it's also the same, just a little bit elaboration. So you can see if there is in peripheral causes, they can have a high creatine kinase with no cognitive impairment, but they have weakness and also paralysis. So you can do first, you go on to the left side, you can see that if the patient present with with areflexia or tongue fasciculation, you suspect for spinal muscular atrophy, SMA. So that's why you need to do genetic analysis. So you go for the SM1 gene testing. So another diagnosis is that you do EMG, electromyography. So if there is any suggestive of myotonia in the patient, so you suspect the patient might have congenital myotonic dystrophy, congenital myasthenia, and some more. So other than that, you can also do muscle biopsy, which can shows any finding in the muscular dystrophy, congenital myasthenia, and so on. Next slide. So for the management of infant with hypotonia, so you need, first of all, you need to treat underlying disease. And another one is supportive management. So for the supportive, you need to refer them to physiotherapy in order to prevent or fracture or any atrophy of the muscles. Next, you also need to refer them to occupational therapy to improve on their posture and as well as their function to ease their daily activities. And if the child or the infant has scoliosis or you suspect hip subluxation, so you need to refer them to orthopedic team for further management. And as they have, as this hypotonia patient, they are immunocompromised. So you need to give vaccination as a prophylaxis against respiratory infection. And another one, as you can see, they have feeding difficulties. So you need also to provide nutrition for them. So you can provide by maybe give a nasogastric tube so that their growth is normal and up to their age. So I think that's all. These are my references. Is there any question?
No questions? Okay, so I will ask the three presenters to prepare neurological examination. Okay. So it may be Amira can go the motor and ataxia. Can you hear me?
Yes, doctor.
The first presenter was Fatin.
Yes.
Fatin will, the three presenter will do for us another simple presentation about neurological examination, because in many situations I found there is a bit weak about the flow during neurological examination. And if you didn't start early, inshallah, hoping we will see you in the ward and see what you are doing. So it is Fatin can do the motor examination. I mean examination for the motor part of the upper limb, lower limb, upper limb, okay? And then Amira will go for two things, which is the cranial nerves examination, okay? And she can get help from other candidate to do the incoordination or ataxia. How can we diagnose it? And the remaining will be for Shami, which is gaits. How can we diagnose the patient from his gaits? How many types of gait, spastic, ataxic, whatever the type, okay? You need to make a good presentation of the nervous system examination. I will see it, inshallah, with corrected points in your presentation. It looks you have, this group have a good ability to present. Thank you for your preparation. I hope, inshallah, in Arabic, we said we need the knowledge to be alone. Can you hear me?
Yes, doctor.
Yes, doctor.
They used to say by Arabic, العلم في الراس مش في الكراس. They mean to say the knowledge is in the brain, not in the book or in the notebook. So we need just to make simple shift all this, if in your mind, it will work very nicely. Thank you for your nice presentation. I think I will give you a degree 8.5 for the 3 team today. Okay, just announce it to the science officer but waiting for corrections, some correction in your presentation. At the same time, we need to do the neurological examination. You can get help of other to prepare it, especially gait. Maybe someone need to present the spastic one, but other need to present the ataxic, hypotonic, whatever the gait problem. and concentrate in pediatric. But in pediatric, we still can see like hemiplegia and like that. The third thing, remember during your investigation to be rational. Why, for any investigation you are requesting, you must give rationale why I'm requesting this one, what I am looking for. Remember also that now for chromosomal analysis, if you don't have frank picture like this Darwin or syndrome or Prader-Willi, which are going to diagnose, there is now the microarray chromosomal analysis. It will detect for the number, numerical. It will detect also for any deletion. It will include like the fish and the other. So it is microarray chromosomal analysis. It will be one sample, can give us all the knowledge. It's your time, your turn if you need to ask any questions. Nothing? Okay. Just remember lastly that the AFP, acute flaccid paralysis, whatever the diagnosis, it is notifiable one. You must notify the Ministry of Health within 24-hour maximum. Even it is not proved as a polio, it is a notifiable disease. Okay. Thank you, and see you inshallah again and again. Hoping we can see you in the world scene soon, inshallah. Assalamu alaikum wa rahmatullah.
Thank you, Doctor.
Salam. Thank you, Doctor.
Doctor.
Okay, doctor.